Diacarta was founded in 2012. It's headquartered in San Francisco in the Bay Area. We make diagnostic, molecular diagnostics, including liquid biopsies, which I'm going to be speaking about some of our work there today. We're certified with ISO 13485 since 2016. We're CLIA certified in the US and in China. We have GMP manufacturing in the US and China, and we're CAP accredited for quality, accuracy, and consistency in laboratory services with clinical trials ongoing and nearing completion as well in the US, EU, and China. We've received several awards. We have multiple patents. As I mentioned, we have sites in both the US and in China with a large operation in Nanjing. So what we first started working on is developing personalized tests to determine radiation and chemotherapy response. And we realized there was a huge unmet need. And this is a pretty basic thing. The patients, when they come to your office, they'll tell you, how do you know, doctor, for me, is the treatment working? Or how do you know, doctor, if I'm going to be the one that gets a side effect? And we have no actionable test right now to answer these questions. We have to examine the patient every week and try and guess. If we had more information, we could potentially raise the dose for some patients. We could potentially change the dosimetry so it's a little bit safer in other patients. Yes. Now, so what does a physician need? Well, they need a test that can tell you when you have subclinical disease. So right now, we have to look at an image and we try and determine whether that image has a living tumor in it or is just an abnormality. And we try and see if it's gotten bigger. We have PET scans, that helps. PET scans are expensive. There's only a certain number you can do. They have a large radiation exposure. So you have tumors that you can see, and then you have tumors that you can't yet see, and then you have tumors that are really in normal size but can grow back someday. And this is the kind of curve that you really wish you could measure in patients so you'd know if the chemotherapy is working, you'd know if the tumor is regrowing. So to do that, we suggested you might need to you might be able to use a liquid biopsy. So if you wanted to design what an optimal liquid biopsy would be, it would be non-invasive because you need to do it many times during the course of the patient's illness, and it needs to be very safe to be done many times. It needs to simulate the histopathology. That is, you need to know how big the tumor is. You need to know what the drug sensitivity is. You need to understand the tumor's biology. It needs to be quantitative. And by this, I mean not just precision, is it there or is it not, but accuracy too. How big is it? How much is it? And that's very difficult for most liquid biopsy techniques. It needs to be quick. You need to know the results before the treatment's over so you can make a change. And it needs to be economical, or you can't afford to do it multiple times. And then you should also be able to not just determine whether the tumor is responding, but also whether the normal tissue is having side effects. We have biomarkers that are pretty good, that are specific for diseases, and truly most of them are simple organ-specific protein biomarkers, like CA-125 for ovarian cancer and PSA. Now, neither of them respond fast enough to know whether the treatment's working in real time so that you could make a change. And CA-125 isn't nearly as quantitative or as reliable for ovarian cancer as PSA is, oftentimes not even being expressed by the tumor. There is great hope for NGS panels. A problem with them is that they're expensive, so it's not realistic to do repeated testing. They are overly specific, okay? They're cancer type specific. They're trained on a specific cancer. They're trained on specific drugs sometimes. None of them have yet been trained for radiation. And frankly, they're done on a certain population, so we don't really know that they'll work between different races. There is slow turnaround. The deep gene sequencing requires an army of engineers to analyze, and it can take weeks. So the answer is not back in the time period that you need to make a decision about changing a chemotherapy regimen or altering a radiation treatment plan. And the precision might be good, but there's limited ability to quantify and be accurate because almost all of them require a DNA purification step, which is never consistent. So towards overcoming some of these problems, and we think we've done a pretty good job, there are weaknesses still. Most tumors most tumors respond to have similar responses to our test. And it is a first in class for radiation therapy. There are no other tests for radiation therapy response. It's non-invasive. That is, it requires a very minimal sample. In truth, we only use 10 microliters of plasma. We, of course, collect a couple of milliliters. The procedure is very simple. There's no DNA purification step. If there was, we couldn't be accurate. So it runs directly. It's reproducible with very high accuracy and precision, as I mentioned, and it's reliable. For a large number of tumor types, we've already shown greater than 90% sensitivity and specificity. Okay, so how do we do it? Well, it turns out that ctDNA is the dominant source of the excess above baseline circulating free DNA. And I won't show you a lot of data on that today because of the time constraints, but I'll show you a little bit. And the key feature here is that because the cfDNA and the ctDNA correlate with one another, you really only need to measure the total. The second thing that we discovered is that radiation is by far the most powerful source of circulating free DNA in the 24 to 72 hours after treatment. So you can easily measure how many cells the radiation killed the next morning after a radiation exposure. So here is just a quick example. The normal, these are violin plots of several hundred patients that had measurements of their circulating free DNA. And what you can see is that the healthy controls have about 10 nanograms per mil in their blood, occasionally having patients that rise over 20. Whereas virtually every kind of tumor we looked at has about 20, that is about twice as much at baseline before any exposure. And some of them, like pancreas, leukemias, and sarcomas, have a little bit higher. So next I'll talk about the evidence that radiation is the most powerful augmenter of the circulating cfDNA in the first 24 to 72 hours. So this is a patient that had a malignant thymoma in her mediastinum. She got a 6 gray fraction. She got 2 fractions a day for 3 days. And you can see 30 minutes after radiation, there is no increase in DNA. 9 hours after, there isn't any increase, but 24 hours, it rises by several orders of magnitude. It stays high, area under the curve, watching the cell death of the tumor and the tumor shrinking for the full course of the SBRT regimen. And the tumor markedly shrunk in that time as well. But you didn't need to take images. We've also shown that in gastrointestinal tumors, normal controls, patients with that have had surgery for their gastrointestinal tumor, and then 24 hours after the first dose of radiation, some patients have a very large increase in their DNA, some patients smaller, but the very next morning, you can see a 4-fold increase in the patient's DNA on average. And the point here being that patients who get GI radiation may not have been on different drugs. They may have different organs in their abdomen treated. And you can get a sense of the amount of cell kill that happened, and therefore their toxicity, and who's more likely to get into trouble. This is a bone marrow transplant patient with leukemia. I think I mentioned that the leukemia patients have a little bit higher DNA after even at baseline, and you can see the level goes up so high it's hard to draw the baseline, because during the course of the total body radiation for the transplant, it goes up by several orders of magnitude before falling over the next few days. And again, this is a measure of the leukemia kill. So you knew the radiation worked. Now, the next question that you have to ask is, well, can we actually see the subclinical disease, the minimal residual disease? And so for that, we looked at 200 patients total, and we did a mathematical analysis of how fast their tumor, their circulating DNA goes down following, in this case, a course of chemotherapy, and then stable disease. So this patient had a partial response and then stable disease from April of 2020 to July of 2021. And this is an example patient. We took the data together, we did the mathematical analyses, and we came up with a sensitivity and specificity using a cutoff of a factor of almost 4 pre to post. So that means pre to post is a factor of 4. And of course, that one was even more than that. And you have, if that happens, you have a 90% sensitivity, 90% specificity for knowing that there was a response. Actually, it's a little better than that. The reverse is also true. So if you have the baseline and a patient has stable disease and they start increasing, same equations, same analysis, and this time the cutoff is, instead of 3.9, it's 3.6. And again, really quite excellent ROC curve with greater than 90% sensitivity, greater than 90% specificity. Again, this is 22 cancer sites mixed together, and we still got this homogeneous response, again, with over 90%. So here's some examples. This is a lung cancer case. The patient had a really excellent response initially, was stable, and then went up by the factor of 3.6 and had progressive disease. But you knew it in advance because the tumor has not yet gotten to above this line, which is the clinical discovery of it on imaging. It's worth mentioning that the partial response and the continued response was documented with imaging on those 2 dates. Here's another case where the original tumor was imaged again at detectable level, and then after response, and then this person had a recurrence, resumed chemotherapy, went back down, and has stayed down at least for the course of that study. This is since 2019 through 2022. Here's a nasopharyngeal cancer. Again, with the same kind of response, the same progressive disease, and then watching that decrease with a new course of treatment, and the same verification of those changes with imaging. We've done this with, I said, lung cancer, colorectal cancer, pancreas, breast. We've done it with gastric cancers. Here's some more data, with lung cancer. And this just shows that it outperforms any of the protein biomarkers that we looked at. So these patients also had a number of protein biomarkers measured, and their ROC curves are good. They're not bad. They range from about 0.6 to about 8. But the problem is that many of these are never elevated in patients. Our ROC curve, again, was really quite excellent for these lung cancer patients, and has a very high sensitivity specificity. Now, we did the same, and this article was published in Oncology a couple of years ago. CFD is the cfDNA, and compared to CEA, C19-9, 72-4, and CA50. And what you can see is that we had higher sensitivity and specificity than any really of the other tests. Remembering that sensitivity can't be high in a test that most patients don't have. Okay, so how is it used? It's very simple. Patients could be getting chemotherapy and radiation at the same time, and then they don't need to get duplicate tests. You do one test before the radiation, one test 24 to 72 hours after the first dose of radiation. Most patients get one at the end of treatment as well, and then can follow the patient over time. And like I said, we've done about 250,000 tests now internationally. Physicians, when they start using it, they get excited about it. It's a first-in-class product. It's a 510(k) de novo by the FDA, and people have to learn that when they learn how to use it. In fact, when the FDA people figured out how it works, they kept suggesting that we use it for other things like figuring out which patients should get treated on a V-ray because they were more radiation sensitive. And they can be followed serially. You can also follow the patients between cycles of chemotherapy, not courses of chemotherapy. So you can actually see, without having to do a PET scan each time, whether or not the tumor is still responding by making measurements between courses, or maybe when it stopped responding and you need to change the chemotherapy. So we can monitor the patient sensitivity. We can monitor for side effects. We can monitor for tumor efficacy, for recurrence, and then prognosis. It's an inexpensive test. It's approved, and it's actually very deployable. It can be done pretty much at any site that does other tests, including PCR or anything with a luminometer or a flow cytometer. Thank you.